Somewhere in Brazil, right now, a woman had an abnormal pap smear result over a year ago and never came back. Another skipped her mammogram twice. A third never got the ultrasound her doctor recommended. No one called for any of them. No system flagged for any of them. And cervical, breast, and ovarian cancer, largely preventable or at least catchable early, get the time they need to become the dead list. This isn't a story about a lack of medicine, it's a story about a lack of tracking, and the solution is Rastreia. Let's start with what the data actually says. According to national studies using CScan and SUS ambulatory records, Brazil's estimated cervical cancer screening coverage is around 35.6%, well below the 70% the World Health Organization recommends. And the gap isn't evenly spread. Coverage is about 44% among white women versus 36% among black and mixed-race women, and it can drop as low as 49% among women with no formal schooling, compared to almost 78% among women with a college degree. Breast cancer screening tells a similar story. National mammography screening coverage in the public health system has stayed under 35% across every single state in recent years, in some northern states under 10%. This is our target, SDG 3.7, Universal Access to Sexual and Reproductive Healthcare Services. And the barrier isn't a lack of exams happening somewhere in the system, it's that CScan, the National Cancer Information System, doesn't talk to the local health unit that actually sees the patient. A woman can have an alter result sitting in the CScan for over a year, and her local UBS has no way of knowing she never came back.
So our solution is Rastreia Mais, a system that sits between CScan, the local health unit, and the patient's actual risk profile across all three cancer types. It's not a new exam and it's not a new treatment. It's the layer that currently is missing, something that actually watches whether the patient comes back and tells the health team if she didn't. Rastreia Mais tracks three things for every patient: her pap smear and HPV vaccination history for cervical cancer, her mammography history for breast cancer, her risk factors such as age, family history for ovarian cancer, which doesn't even have a national screening program yet. So basically your system cross-references CScan records against local UBS records, and when someone falls through the gap, it flags her. So basically it will automatically tell when a patient needs to return to the UBS. So instead of waiting for her to remember, our system just warned her. The system has 4 layers. First, registration and history. Every patient exam history, results, vaccination status, risk factors across all 3 tracks. The second one is data integration. It's a cross-checking CScan against local UBS records to catch anyone lost between those 2 systems. The third, it's risk engine, and there's a decision we made deliberately. We started with simple clinic rule logic, not machine learning. So for an example, unaltered exam, plus more than 12 months without a return visit, plus risk age package equals high priority. So we didn't use machine learning or AI for any of that because we trust our clinic rules and the clinical process. And fourth, we have the UBS dashboard, and this is what the health team actually sees. And for the first time, our health unit can literally see where its prevention programs has holes, not in just aggregated statistics, but patient by patient. And here's how we actually built this. So the phase 1, which is our months 1 and 2, an MVP built on a simulated database. So we had fictional results. We started with cervical and breast tracking since CScan already has strong public data for both. This provides risk detection logic and without actually needing governmental authorization to touch patient data yet. Phase 2 was month 3 and 4, so it's basically built based on the UBS dashboard and stress test the risk engine against simulated abandonment cases. The phase 3 is months 5 and 6, bringing the dashboard to a real UBS or health professional, not for deployment, just for feedback. We want to know what we got wrong before we scale anything. In phase 4, it's further out. So it's a formal Syscan integration, an LGP complaint notification channel, and expanding ovarian risk factor tracking as we build the right data partnerships. We would like to note that we are not promising real Syscan integration by month 1. That would need institutional authorization that we don't have yet. But we want feedback, we want to test our prototype to make sure that we'll actually supply the needs of our public.
On the human side, this needs a small development team covering backend, dashboard, and data, a health professional to validate our clinical rules against real practice, and someone responsible for reviewing our LGPD compliance before we touch any real patient data. On the funding side, the MVP phase is generally low cost. It runs on open source tools, Python and PostgreSQL, a free hosting tier. It's mostly our own time. The pilot phase is where we look for a partnership, a municipal health program department, or a university public health program for validation and feedback, not a big capital investment. We're not asking anyone to fund something unproven. We're asking for a conversation once we have. Long-term, Rastreia doesn't need new hardware or new infrastructure. It can run on the computers UBS units already have. And because it makes an existing public health program more efficient, instead of creating a brand new one, it could eventually fit inside budgets municipalities already allocate for preventative care, rather than competing for new funding. We want to be upfront about the risks. First, privacy. This is a sensitive health data, and LGPD compliance isn't optional. Our MVP uses anonymized simulated data specifically so we can prove the concept without the exposure yet. And any real deployment would need proper consent flows and access controls from day one. Second, integration risk. Syscan may not open real institutional access easily, which is exactly why our MVP doesn't depend on it. Third, option risk. A dashboard doesn't help anyone if health workers aren't trained to use it or to trust it. That's why our phase 3 pilot is about feedback, not deployment. So what does success actually look like? We track 3 numbers: the percentage of patients recovered from follow-up abandonment after 12 months of use, the change in each UBS screening coverage rate over time, visible right on the dashboard, and the time between an auto result and the patient's return visit, before and after Rastreia. Given that national cervical screening coverage sits around 35% against a 70% target, even a modest measurable reduction in follow-up abandonment translates into real early diagnosis that wouldn't happen otherwise.
My name is Nae, and I've worked on the coding and the building process of the prototype of the Rastreia Mais.
Well, I worked on the idea itself and advocacy with politicians to actually implement